Good morning, and thank you, Professor Kim and Dr. De Oliveira, for this opportunity. Well, we're shifting gears now from transplant surgery to pancreatic cancer. One of the main problems with the dismal prognosis associated with pancreatic cancer is that only a fraction of patients present when the disease is actually resectable. Now, the good thing is over the last few decades, with an increase in the experience with pancreatic resectional surgery, vascular resections, reconstructions, the inputs from critical care, interventional radiology, and radiology as a whole, has enabled the pancreatic cancer treating surgical fraternity to now look to shifting their gaze from not only salvaging resectable disease, but the next big large cohort of non-metastatic tumors, which is locally advanced pancreatic cancer. Now, locally advanced pancreatic cancers are those which do not have distant metastases, but traditionally people have looked at them as unresectable because of their relationship to the important veins or arteries or possible involvement. And it is from a concerted effort to try and make these patients resectable that was born this new subset of patients called borderline resectable pancreatic cancers. Now, in the definition that was first proposed by Gauri Vardachari and the group from MD Anderson, these tumors were defined as those large ones that were located next to the superior mesenteric vein or portal vein, and in whom a surgical resection, with or without a vascular resection, was certainly possible, although the incidence of margin positivity was much higher. And so these patients could potentially benefit from neoadjuvant therapy. Now, the need for a more objective definition was sought, and thus Dr. Mark Callery and a group of surgeons from the American HPB Association got together and gave us a consensus definition for borderline resectable tumors. And I'm quickly going to rush through this just to get you all up to speed. So the bottom line is there should be no distant metastases. The rest of the definition is initially a radiological one, which defines contact of the tumor with the important veins. And when I say contact radiologically, we mean loss of fat planes. Now, the tumor, if it has less than 180 degrees circumferential contact with the SMV or portal vein, is called abutment. If it's more than 180 degrees up to 360, it's called encasement. And if there is compression or occlusion of the lumen, that is also included as borderline resectable, so long as a safe resection and reconstruction can be possible. Now, at this point, safe resection reconstruction is one thing, survival is something else. Now, this definition certainly does not tell you how much of a length of vein should be involved. But if you take a paper from Kanioka and colleagues, they found that when more than 3 centimeter length of the SMV or portal vein is involved, that's associated with a significantly poorer survival. So my ballpark figure would be somewhere less than 3 centimeters would be included under borderline resectable if we had to have an objective number. Now, even in terms of arterial involvement, an encasement of the gastroduodenal artery, so long as the tumor does not reach the celiac axis, is still borderline, and also abutment of the SMA when the tumor does not make contact with the mesenteric vein. Now, what's the best investigation to diagnose borderline resectables? Well, we've reviewed the data extensively, and what we found was that multi-detector computed tomography scans performed on a 64 slice in the triple phases of arterial, venous, and pancreatic is the most useful. There is emerging data for MR and MR angiography, but let's be frank here, CT scans are much more widely available the world over, and more importantly, it's the technical expertise to read and interpret these scans that's very widely available. And thus CT tends to be the first investigation and often the last investigation performed. Now, you could perform an endoscopic ultrasound to better delineate vascular involvement if this is really suspected. Now, as surgeons, we asked ourselves the first question. Very often with borderline resectable tumors, you can get in and you don't need to perform a vascular resection. You can actually dissect the tumor away and still have an R0. So to be better prepared for the surgery the next morning, were there any clues in radiology that could tell us, yes, 100% this patient is going to need vascular resection, so get your grafts ready and be prepared? So we retrospectively analyzed our radiology and this was before the NCCN definitions. So we found that if there is circumferential contact more than 180 degrees, what the NCCN now defines as encasement, or if there is narrowing of the vein, we call it venous deformity by more than 50% of the diameter, which the NCCN now refers to as occlusion. These are highly predictive of the need for a vascular resection. And to get the most out of your radiology, you need to perform the imaging as close to the planned resection as possible to avoid the surprise of subradiological metastases. Now, coming on to management. At this point, there's a lot of controversy. Should we perform upfront resections? Should we offer these patients neoadjuvant therapy? Well, let's look at each of these modalities one by one with the evidence that's currently available. Upfront surgery, there are no randomized controlled trial data. The only randomized controlled trial that was started by Brunner and colleagues had to be prematurely terminated because of poor accrual. So what then do people talk about when they say, yes, evidence-based, we should offer or at least consider upfront surgery? What they're doing is they're extrapolating data from resectable pancreatic cancer. See, today, based on mouse models and then genomic data, and simply the fact that even when we do an R0, when patients recur, they recur at distant sites, we believe that pancreatic cancer is a systemic disease at presentation. So there are groups around the world who, even in resectable disease, are offering their patients neoadjuvant therapy. And so their studies that they've compared neoadjuvant therapy versus resectable versus upfront surgery, for resectable disease, is what's being spoken about when people are talking about borderline resectable. So do we not have any data then? Well, we have a very good paper from Cato and colleagues with a huge experience of more than 500 borderline resectable tumors that was published last year. And what they found was that arterial involvement is associated with significantly poor outcomes. R0 resections should be the game. And neoadjuvant therapy has a significant improvement in survival. See, the advantages of doing an upfront surgery is you don't need a biopsy. The next one is there's often this line that's played on which says 16 to 20% of patients progress while on neoadjuvant therapy. And I'm going to talk about this statement a little later. And finally, in our own experience, we find that tumor-induced acute pancreatitis causes a bit of dilemma when interpreting scans, and radiologists tend to overcall vascular invasion. But we must remember that there is strong data to suggest that pancreatic cancer is a systemic disease. Surgery remains the cornerstone for the management of pancreatic cancer, but chemotherapy adds significantly to the survival benefit. Now, Professor Neoptolemos's group have done a subset analysis of their SPAC data and found that it is the completion of chemotherapy. Now, this was in the adjuvant setting. In fact, there's a paper by Zheng and colleagues earlier this year which says completion of chemotherapy in the neoadjuvant setting. These are the most important determinants of the benefit of chemotherapy. Now, wherever pancreatoduodenectomies are performed the world over, they are associated with morbidity that may reach even up to 50% in some of the best centers. And even if a patient does not develop a complication, some of our older patients don't actually even recover after the physiological switch that we induce as a result of a PD. And thus, 25% of patients at least will never even come up for adjuvant therapy. So we are denying them that chance of a survival benefit. The other important thing is that across all neoadjuvant studies, they've shown us that R0 resection rates are possibly better. Now, this assumes significance when there is a true venous involvement. If it's just an inflammatory adhesion to the vessel and you can dissect it off, that's all great. But when there is a true venous involvement, survival is significantly poorer. And thus, these patients could possibly benefit from neoadjuvant therapy before surgery. These are some of the references from the studies that I've quoted. So what's the data on neoadjuvant chemotherapy? Well, To be honest, it's very confusing at the face of it. The studies have included borderline, locally advanced and metastatic disease. There are studies that have gemcitabine in monotherapy and gemcitabine in combination therapy. And then there are other studies that have chemo or chemoradiation or both. But a more critical analysis was performed by Professor Fries's group and Gillen, which was published in PLOS Medicine. And the common thread is that gemcitabine in combination therapy has good response rates and good resection rates. There is also very good emerging data for FOLFIRINOX. This paper is going to appear in the Annals of Surgical Oncology very, very shortly. It's by Rose and colleagues, where they have continued giving neoadjuvant if they have not seen a good response for even up to 24 weeks, and then had a resectability rate of 48%, which is pretty decent, and R0 of 87%. See, the advantages of neoadjuvant chemotherapy is that you start the therapy when the patient is relatively healthy, so you have a shorter therapy. Your chances of completing therapy are much higher. Better resection rates are also seen. And yes, if the patients do progress while on systemic chemotherapy, it could be a reflection of the poor disease biology. What about chemoradiation? Festa and colleagues have summarized their data in a single meta-analysis published in the JOP last year, where they've said, although people talk about chemoradiation, we are not seeing the downstaging that we wish to achieve. And we are doing, even if we do so, it's at the cost of a lot of toxicity. But still people keep saying, no, chemoradiation is better than chemotherapy. Even in locoregional disease, a very qualitative systematic review by Huguet and colleagues has shown us that upfront chemoradiation in locally advanced pancreatic cancer was not associated with a significantly better survival than just systemic chemo, and was certainly associated with more toxicity. There have been 2 randomized controlled trials trying to compare the 2 modalities, but both of them had to be prematurely terminated because of low accrual. So the way this presentation seems to be going is neoadjuvant therapy might be the way forward. Well, as a surgeon, my biggest question is, will neoadjuvant chemotherapy affect my surgical outcomes? And we have some data from Europe, from the United Kingdom, and also from Italy, which says, yes, the resections are a bit more technically demanding. Patients may stay a little longer, but there is certainly no significant increase in the morbidity or mortality. So come again. Chemo, chemoradiation, combination of chemo and chemoradiation. Pancreatic cancer is a systemic disease. The 16 to 20% that you saw earlier, this number of patients who progress when on neoadjuvant therapy is a number that's been obtained from studies where not all patients had a diagnostic laparoscopy before starting. We know how radiology can miss peritoneal metastases. So just imagine you're giving a patient who may be having peritoneal disease locoregional therapy in the form of chemoradiation. I don't think the chemoradiation or neoadjuvant therapy had a chance. And this is possibly one of the more important reasons for patients to progress, although it is not the only reason. And they could possibly progress because of poor biology. So taking all this information together, what's the verdict? What do we do when the next patient with borderline resectable walks into our clinics? Well, I think it's only fair that we should offer them systemic chemotherapy to start with. Now, once they complete the initial cycles, if they have a good disease regression, just go ahead and offer them surgery. Now, at this point, if they do have you complete an R0 resection, just complete the chemotherapy. Whereas if you have an R1, which is a microscopic positive margin of resection or node positive disease, you could consider chemoradiation. Now, if you have not a good response or a bit of progression but still locoregional disease, then you could add chemoradiation. The problem comes when you have stable disease. Well, Katz and colleagues have shown us that radiological tests are not the best to assess response to neoadjuvant therapy, and they found that as long as the patient has stable disease, just go ahead and do a surgical exploration. You have a good chance of resecting the disease. So that's one thing that could be considered, or you could still try and give them locoregional therapy and then go on to surgery, because surgery, they need to have an attempt so long as they don't develop metastatic disease. What can we look forward to in terms of borderline resectable? Well, there's a multi-institutional single-arm study called the Alliance study that's going to give patients FOLFIRI-NOX, followed by CAPE-based radiation, and then assessment for surgery. There's a currently undergoing randomized control trial in the Netherlands where they're randomizing patients to either upfront surgery or chemoradiation followed by surgery. And certainly not to be left behind, the importance of molecular biology. There have been two big groups from around the world, amongst others, who have been looking at markers and biomarkers. Now, Iacobuzio, Donoghue and colleagues have given us the four most important markers in pancreatic cancer progression. There's KRAS and P16 in the early disease, then P53 and finally SMAD4. Now, on the other side, we have Andrew Biankin and the International Pancreatic Genome Consortium, who have found S100A2 and A4. Now, S100A2 and A4 and SMAD4, these are markers which can be detected much before metastases can be phenotypically seen. So that's the advantage of these markers. And potentially, if you find these markers and the patient does not have metastatic disease, you could still take into account the fact that these patients are going to develop metastases within the year no matter what you do. Because these are patients who have actually undergone aggressive surgery and chemotherapy and have been retrospectively studied. So these patients could possibly be prevented from going through a more aggressive regime. Well, finally, it's been a year since I've moved to Medanta. We've had about 68 Whipples done in the last year, more than 15% of which have been borderline resectable, and I'm happy to discuss our data maybe over a cup of coffee. Thank you.